Hi, this is Sharon Holthouse. I'm going to be talking about study question 510, long volumes and capacities. In this study question, I'm going to be describing the values um, and the meaning of different long volumes and capacities. And then we're also going to look into some abnormalities that we find in lung tissue and talk about how that affects the ventilation that occurs in the lungs. So a lot of lung volumes are measured by something called spirometry. And this measures a person's pulmonary ventilation. And remember, ventilation is simply the movement of air in and out of the lungs. And a patient breathes through a device such as this, and it's able to record the rate that air is flowing through the device and also records the volumes that a person is either inhaling or exhaling. So when a test like this is done, you have a recording of these volumes, and we're going to look at some of the typical volumes that are studied or that are, I guess, of interest when looking at someone's lung ventilation. So this graph has a lot of things going on here, but let's just get kind of oriented. So on the y-axis here is the volume, lung volume, measured in milliliters. And really, down here on the x-axis, we could think of this as time. So a person would be breathing in and out in a relaxed way here, and then I'll describe some of these different changes that we see in the graph in a minute. All right, so first of all, we will start with what's called the tidal volume, and that is shown in yellow here, and it is simply the volume of air exchanged in a single normal breath. And if you look at that amplitude from here to here, that is about 500 milliliters. Now, all of the values on this graph are for an average healthy adult male. Males tend to have larger lung capacity than females do, simply because their body size is bigger. Taller individuals will also have greater lung volumes. So you could have a tall woman who has greater lung values than a short man. There are some other factors that affect normal lung values. For example, if you grow up in an area of very high altitude, and then also there are some problems or diseases that would affect these volumes. So anyhow, I kind of digress there, but getting back to this tidal volume, I like to think of the tide, if you think of a tide coming up a beach or up a shore and then kind of going back, and it's a relaxed in and out, inhalation, exhalation, and in a single normal breath, again, that volume is going to be about 500 milliliters. All right, the next volume we'll look at is called the inspiratory reserve volume. And that volume is shown right here. And it's the additional air beyond the tidal volume that can be inhaled with maximum use of the inspiratory muscles. Okay, so what that means is if someone puts a cake full of candles in front of you and you need to blow those candles out, you're going to inhale or inspire as deeply as you can. So a typical value for that, if you look on the scale here, 3 to 6,000, so that'd be 3,000, okay, is the typical value for inspiratory reserve volume. So you're really working to inhale as much air as possible. The expiratory reserve volume is shown here in this darker blue color. So that is the additional air beyond the tidal volume that can be exhaled with maximum forced expiration. And that is not as big as the inspiratory reserve volume. That's about 1,200 milliliters for an average healthy adult male. So that volume would be, once you go to blow out those candles on the cake, how much air can you force out beyond your tidal volume, or what you would normally exhale in a fairly relaxed breath. And the next value I want to talk about is the residual volume. And residual volume is the volume of air remaining in the lungs after a maximal forced expiration. So even when we try and blow as much air as we can out of the lungs, there will be air remaining. And that's a good thing because we want to keep the alveoli and the airways open. We need that residual volume in there to keep those alveoli inflated. It wouldn't be a good thing if we could blow all of that air out. Okay, so a standard value for residual volume is 1,300 milliliters. All right, so the title of this study question is Lung Volumes and Capacities. A volume is simply measured through the spirometry, where a capacity is one or more volumes added together. So let's look at vital capacity. That's shown from here to here, so you can see it involves 3 different volumes that we already talked about. It involves the tidal volume in yellow here. It involves the inspiratory reserve volume added to the expiratory reserve volume. Okay, so it's the sum of those 3 values, tidal volume, inspiratory reserve volume, and expiratory reserve volume. And it's the maximum volume of air that can be exchanged in a single breath. So a single breath would be that inhalation and exhalation, and that total volume is typically about 4,700 milliliters. So that's vital capacity. Total lung capacity, that spans this whole graph here. So total lung capacity is the total volume of air in the lungs after a maximal inspiration. Okay, so that would include your vital capacity here, plus your residual volume. And that total lung capacity for a healthy male is 6,000 milliliters. One other value that the study question asks you to address is something called dead space. And dead space is the air in the upper and lower respiratory tract that is not in the alveoli. So in other words, there's some air that moves in and out of the lungs, but it never gets to participate in gas exchange because it never reaches the alveoli. So it's dead space because it's not part of the CO2-O2 exchange, but it is still air that is moving in and out of the upper and lower respiratory tract. And that value is 150 milliliters. All right, so this is a summary from your textbook, The Respiratory Volumes and Capacities for an Average Young Adult Male. So that summarizes much of what we just talked about now, but it's a nice reference tool for you. right, the next thing we want to look at is the forced expiratory volume. This is often referred to as FEV, and it's the volume of air that can be expired in a given amount of time. Oftentimes, what's measured is the volume of air that can be expired in 1 second. If that is the case, then this is called the FEV1. So this is an important measurement in when subject's FEV is being measured. He or she will exhale as rapidly as possible. And the FEV differs from vital capacity, which simply tells us how much air the subject can exhale. With vital capacity, it's the total volume, and time doesn't matter. FEV, or as particularly if we're looking at FEV1, that measures how much air is exhaled in 1 second, or the rate of the exhalation. Okay, so this is relating to speed and volume. Okay, so the subject takes a deep breath and blows out as hard and as quickly as she or he can. They're forcing out the air as quickly as possible. Okay, so time is a factor in this FEV measurement. Oftentimes, the ratio of the forced expiratory volume in 1 second over vital capacity is used as a measure of respiratory health. And in 1 second, a person should be able to blow out 75 to 85% of their total vital capacity. Okay, so that means that they're blowing out 75 to 85% of the air in their lungs in that first second. So if the percentage is lower than that, then the subject has a decreased or diminished FEV, and that may indicate some type of respiratory problem, perhaps emphysema, chronic bronchitis, or asthma. And we'll talk about some of those conditions in a moment here. All right, I want to talk about surfactant. Surfactant is a thin layer of moisture on the inside of the alveoli. So here's our sac of alveoli here, and this cutaway here shows up close one alveolus, and the lining of each of these alveoli is coated with a fluid, and this fluid is called surfactant, and it's a combination of phospholipids and proteins that keep the alveoli from collapsing. It's produced by a specific type of cell in the alveoli. It's called a type 2 cell. And the surfactant acts as a detergent and helps decrease surface tension. Okay, if these alveoli were just coated with water, if you think back to AMP1, we talked a lot about the different characteristics of water and its high surface tension due to the number of hydrogen bonds. So one hydrogen bond is not that strong, but you have many hydrogen bonds together, as in water, and the surface tension is very high. And what that means is if there was water coating the alveoli inside, if an alveolus collapsed, the walls would stick together like two wet pieces of paper, or you've probably set a wet glass down on a counter and felt how there's adhesion, a stickiness between those two surfaces. So surfactant decreases the surface tension and it decreases the likelihood, that the alveoli will collapse shut. And if an alveolus would collapse shut, there's much greater chance that it will reinflate with the next breath. It's going to be a lot easier to reinflate that air sac with the surfactant present. The detergent acts to break apart those hydrogen bonds, and so if an air sac collapses, the two sides aren't going to stick so tightly together or adhere together. So one problem that happens when a baby is born early is there's something called respiratory distress syndrome of the newborn, or often it's called infant respiratory distress syndrome. So premature babies do not have surfactant developed yet. And the surfactant typically develops around 7 months of gestation. So if a baby's born prior to that time, the lack of surfactant makes it much more likely that the alveoli are going to collapse. And when the baby takes the next breath, it's going to take a ton of effort to try and reinflate those alveoli that are stuck together, because it's lacking that surfactant and those alveoli are going to stick together. So this is very exhausting for a premature infant. It takes tons of energy. One thing that can happen is the surfactant can be provided as an inhalant that helps coat the air sacs. It's possible that the baby might need breathing assistance, and that could be done through positive pressure where the air is kind of forced into the lungs and it helps keep those alveoli open. Or possibly ventilation where there's a machine that's basically doing the breathing for the infant. Okay, so very important coating inside of our lungs. All right, I'm going to talk about two different types of obstructive diseases. And the first one I want to talk about is emphysema. This is often referred to as chronic obstructive pulmonary disease. And what happens is the alveolar walls break down. So you end up getting enlargement of the alveoli. If we look at this drawing here, you can see this is representing normal lung tissue. It's a cross-section through some air sacs. So these are the walls of the alveoli. And with emphysema, you can see that some of those walls have been broken down. So it's almost like one alveolus or air sac may join another one, and you have a much bigger area. And there's much less respiratory membrane available for gas exchange. So we get a decreased gas exchange with that lack of respiratory membrane. There's also a loss of recoil in the lungs due to a loss of elastin. And we've learned how important recoil is, particularly for exhalation. Remember that inhalation is an active process. We use respiratory muscles to do that. And exhalation is primarily, particularly at rest, it's a passive process where the lungs are recoiling. In a person with emphysema, there's a lack of that recoil. So there's particularly difficulty with exhalation. Now remember that measure that we talked about, the forced expiratory volume. A person with emphysema would likely have difficulty breathing air out quickly. Have a hard time getting that air out forcefully and as quickly as possible. So because there's a difficulty with exhalation and a loss of recoil, air is retained in the air sacs, and this air is basically stale. It's higher in carbon dioxide and lower in oxygen than normal. Emphysema is most commonly caused by smoking. There could be other lung irritants, perhaps in someone's workplace, or living in a very, very polluted place, or possible hereditary problems, but smoking is definitely the most common cause. So with this difficulty in exhaling, an individual with emphysema works very hard to breathe, and they will likely recruit additional muscles to help exhale. While it's normally a passive process, they'll be using a lot of energy to move air out of the lungs, and so a person with emphysema is often quite fatigued. Asthma is the other obstructive disease I'd like to address, and asthma involves the bronchioles, or the small tubes in the respiratory tree, and it involves inflammation as well as bronchospasm. A person with asthma will often have shortness of breath, wheezing, coughing to try and open those airways, and what's described as a tightness in the chest. So if we look at this diagram, here's a normal airway. This is a cross section showing the alveoli at the end, and here's the bronchiole. So this is a normal airway, and this is an asthmatic airway, and you can see that the wall is inflamed and thickened. Okay. So this inflammation, again, it's difficult to expire or to exhale. And so a person with asthma would also have a decreased FEV. Forcing air out of the lungs very quickly is going to be a difficult challenge for someone with asthma. Okay, so there's this inflammation that's involved. And then also what can happen if there's some type of irritant. This could be an allergen, it could be cold, it could be exercise. Something irritates the airway and it goes into bronchospasm. And there's smooth muscle that's lining the walls of the bronchioles. It contracts and it decreases the diameter or the opening of the bronchioles. Okay? And that decreased airway, again, you can imagine that trying to exhale through a narrower tube is going to be a lot more difficult than exhaling through a normal airway. Asthma is typically treated with bronchodilators. These are usually delivered or always delivered in the form of an inhaler, where someone inhales bronchodilators that help relax that smooth muscle and open the airways a bit. And then the inflammation is often treated with anti-inflammatory drugs. All right, so that's it for study question 510. We looked at spirometry, the measure of lung volumes and capacities, looked at normal values for a healthy male, talked about the differences between males and females, and the importance of height as far as determining lung volumes and capacities. We also talked about the forced expiratory volume and how that gives us important information about how quickly someone can exhale air from their lungs. And then we looked at the importance of surfactant in decreasing surface tension and helping keep our alveoli open. And then finally, we looked at emphysema and asthma, two obstructive diseases. They are often chronic. And both of these would give us most likely a decreased FEV over vital capacity ratio. So that's it. We'll see you soon, and I hope you have a great day. Thanks.